Okay, so first of all, I feel quite short here. I need some stool to stand on. For those of you that don't know where Leeds is, it's right in the centre of the United Kingdom. So if you put a pin in the map, it spun the United Kingdom, you'd be in Leeds. This is my dental school. It was built in the 1970s, so it's not the most beautiful, but it's a very good school, and I'm very proud to work there. And the city itself is very beautiful. Not as beautiful as Madrid, I have to say. So I'm going to draw upon a number of experiences to talk to you about ICDAS today. We have an ongoing study in the United Kingdom called Fiction. It's a randomised controlled trial looking at 3 different methods of managing caries in the primary dentition. And that study's using ICDAS. There are around 80 dental practices and over 1,000 children. We have another study, again, across the United Kingdom called Interval, again using ICDAS in 53 practices, and this time it's with over 2,000 adult patients. A much smaller study that I'll speak to you in some detail about is the incentive study, where ICDAS was used as part of the baseline examination for around about 500 adult patients in a study where we were trying to look at the effects of providing more incentives for prevention in dental practice. Now, going back some time, in 2008, there was the Eagle Head 2 study, and I don't know if any of you were involved in that. That study was quite extensive, with 146 dentists from 9 different countries using ICDAS. Most of the examiners there had used ICDAS for the first time, and they undertook nearly 3,000 examinations. And then a very tiny study. One general dental practitioner who really didn't believe that ICDAS was a practical way to record caries, and he agreed to undertake a study for us with just 100 patients, children, adults, but he gave us some very useful information and insight from a practitioner's view rather than an epidemiologist's view. And then the last study is, again, a very small one, but set up to look specifically at the differences that you could anticipate if you used ICDAS versus other measures of epidemiological use for a caries measure. That was just with 8 trained examiners and 24 children, but some interesting results. And much of the experiences that I'll talk about to you this morning come from working on training and calibration and epidemiological studies from all over the world. So may I ask, who amongst you has used ICDAS before? Can you put your hand up? That's excellent. I recognise a number of people from having met in Valencia on a course there, which was wonderful, and I'll mention that later. Afraid this stopped working. Apologies, I think I've given the computer too much to think about with lots of pictures in my presentation. It's just very slow to move. Sorry. Okay, so I'm going to cover today First of all, for those of you who haven't used ICDAS and maybe don't know what ICDAS is, I'm going to very briefly talk about what the International Caries Detection and Assessment System is. And then I'm going to talk about the practical issues that are common to most uses for ICDAS. And then talk about some specific issues in relation to clinical practice, research, and then spend a little bit more time on the practical questions that might arise when you're using ICDAS for epidemiology in particular. Throughout, I'm going to refer to resources that you'll find freely available from the ICDAS Foundation and encourage you to use them. We spend quite a lot of time preparing these, and I'll introduce you to them as we go through the talk. I'll also mention ICCMS, and that's the International Caries Classification and Management System. Because we realise with ICDAS that an index without some instructions to help people apply for treatment was not very useful. So more recently, there's been some guidance produced linking the ICDAS codes to other diagnostic aids and to treatment decisions. Okay. So first, the quick introduction to ICDAS. So, as the terminology says, it's a caries detection and assessment system. And it came about because detection and assessment of enamel caries is essential in this modern era of preventive dentistry. As the initial speakers eloquently said, we must prevent caries. We must actually act before it's too late to do benefit for patients. And waiting for cavitation is too late to plan or institute appropriate care. So maybe some of you will have seen this before. It's an unpublished piece of work, but it's very interesting. And it highlighted that not all ways of measuring caries were equal, even when the criteria systems look very similar. This is the Eurocaries study. This was run in Dundee many years ago now, and we invited examiners from mostly Europe, from Germany, Switzerland, England, Ireland, Scotland, England, and 2 examiners from the United States. And what we did was we invited them to come and examine the same group of children, 12-year-old children. And each of them brought their own criteria. These examiners were gold standard examiners for their national surveys. And most of the criteria actually looked very similar. The majority of them measuring caries at the dentinal threshold, so recording only caries that was interdentine. But on the same group of children, this is the variation that we found in the amount of disease that's recorded. And if you focus only on decayed teeth here in red, you'll see that across the examining systems, the number of decayed teeth in this group of 12 children varied from around 10 to almost 40. So the criteria systems themselves looked very, very similar, but their application was very different. A small number of the criteria systems also measured caries in the enamel. And you can see the variation there was even more noticeable. So this was one of the things that contributed towards the development of ICDAS, to try to have one standard measure for caries that could be used across the nation. So what is ICDAS? Well, it's a system of caries detection and assessment that reflects our current scientific understanding of caries. It's based on histological validation. So the descriptions of the codes that you see that stage the disease from sound through to cavitation actually relate quite well to the histological depth of the caries itself. The idea behind ICDAS was to promote a valid comparison between different studies, different surveys, and between clinical practice, to help promote comparison at different points of time, in different countries, and in different locations, settings. The ICDAS criteria is predominantly visual. That means that there is no use of a sharp explorer. I'll talk about this in a little bit more detail very soon, but it's important that the ICDAS is considered to be a visual criteria system. It also depends on the teeth being clean and dry, and the system's used in a consistent way with a 2-digit coding. And in some instances, we also add in an activity code to record whether the disease is active or inactive. So this is what ICDAS looks like. I always think it's quite much easier to think about ICDAS from the worst stage through to the least. So these two codes are very, very straightforward. Code 6 is cavitation exposing dentine with more than half of the tooth surface involved. Code 5 is also cavitation exposing dentine, but with less than half of the tooth surface involved. The rationale between having these two different distinctions was to attempt to help with backwards compatibility of systems. In most systems, there's a code for caries that involves the pulp. I would consider that most Code 6 lesions would be that. Before the breakthrough into dentine, we often see what's sometimes called hidden dentinal caries. It's become more prevalent as more fluoride use has been in place, and it's often seen as a dark shadow underneath apparently intact enamel. It can be dark, grey, or brown, but it's usually very noticeable. When I do the training and calibration exercises, often people start to see shadows when there are no shadows. So I don't know if any of the people that have been on courses with me before will remember, but I always make them say, "Give me £100 if you're wrong." So you must be certain before you call a code 4. Interestingly, in the mouth, these lesions are often seen better when the tooth is a little bit wet. And that's because it helps the translucency of the enamel that's overlying the caries. Most of the other codes are easier to detect when the tooth's actually dry. So we're going to now switch to the earliest codes and come back to the middle. A sound tooth surface is one where there's no signs of caries, even after air drying. When people first start to use ICDAS, sometimes a revelation that when you blow air onto a smooth surface in an area of plaque stagnation, all of a sudden a white spot lesion will be revealed. And that's a code 1 on a smooth surface. The loss of enamel has made the surface more porous. But in the very earliest stages of caries, that porosity is infilled by the saliva. If you air dry for 5 seconds, you drive the saliva out of the lesion and its optical characteristics change and the white spot is revealed. When there's been more loss of enamel and the enamel surface has become even more porous, its optical characteristics are changed so much that the saliva can't fill in the gaps. And so you see a scar on the tooth surface, what we'd normally notice in clinic as a white spot or a brown spot lesion. And then what happens next is the porosity gets worse and the surface of the enamel starts to break down and cavitate. And that's a code 3 when you've got breakdown of the surface itself. So that's a quick run through the codes of ICDAS. There are some jiggery-pokery things that we do in pits and fissures to differentiate between codes 1 and 2. But I'll leave that for another day. So I mentioned that ICDAS uses 2 digits, and this is to help us record all eventualities on tooth surface. The first digit is this, and it relates to the restoration status of the tooth surface. You have all of the different things that you might want to record. So in this example here, we have a fissure sealant that isn't filling the whole fissure system. So that's a code 1, partial fissure sealant. I don't know if you can see well, but there's dark grey underlying shadows here, indicative of dentine caries underneath that fissure sealant. And that would be a code 4. So on the occlusal surface, this would be a code 1-4. Of course, we have codes to help differentiate the different causes of a tooth being lost. I think this was one of the forms that we used in Valencia. I'm hoping it's Spanish. Is this familiar to anybody? So the surface charts are done surface by surface for every tooth. And this box here on the bottom allows for shorthand coding. So if there's a crown on the tooth, for example, then this box can be used to record it. Or if the entire tooth surfaces are sound, then zeros can be placed in this box. And I'll show you what a difference that makes to looking at the charts later on. It does make them much more clear. ICDAS was designed not just for epidemiology. And sometimes people forget that ICDAS isn't just an index of caries for epidemiology. It has been designed for use in clinical research, dental education, and clinical practice. And it's become far more relevant, I think, by the introduction of the ICCMS guide to help clinical practice. Okay, so it's important that you know if you're going to use ICDAS, the first practicality is that there are some prerequisites. If you remember back to when you learned about dental caries, you'll know that caries forms only in areas of plaque stagnation. It doesn't form where the plaque is transient. And so the common areas you can see here are at the gingival margins and in the aproximal areas and in deep pits and fissures. So all of the areas where plaque is difficult to remove. So fundamentally, if we're doing clinical research or an epidemiological survey and the teeth are not clean and we want to see enamel caries, then unfortunately it will be hidden. So the ICDAS system is used only after cleaning the teeth. I'm not going to show you a picture of somebody cleaning their teeth. I'm going to show you a partially erupted tooth that's covered with plaque that during a survey you could easily consider to be sound. However, when the tooth surface has been cleaned, you should be able to see here that there is quite extensive enamel caries affecting the base of the pit and fissure. And so cleaning the teeth is fundamental. And it doesn't matter which type of ICDAS coding you use, the teeth must always be clean. Otherwise, it's not ICDAS. Secondly, the avoidance of the use of sharp probe. Now, this is my first practical thing that I learned when teaching ICDAS. If there's a probe on the bracket table, the dentists will use the probe. And I'm hoping that all of you dentists here that are still learning are learning not to use the probe so that you don't become reliant on it. I always say for us old dentists, it's like a walking stick that we can't do without. And so when I teach ICDAS, I usually have 2 mirrors placed in the hands of my examiners, because these are the best tools to help you find caries. I'll show you the kind of damage it can do. You can see here a magnified image of an area of the fissure system that has enamel caries. And when probed, unfortunately the sharp probe used with force in a tactile measure damages that very softened surface. So enamel that has already been weakened by dental caries is very vulnerable to sharp instruments. So in the ICDAS system, we equip the dentists with a ball-ended probe, but we still try to make sure that people understand that it's not for feeling the tactile nature of caries. As you can imagine, you've probably been told this many times, in a narrow fissure system, we used to rely on the tactile nature of the probe sticking, and that would tell us there was caries there. But in actual fact, that only told us that there was a narrow fissure system, potentially, that was trapping the probe. So when using the ball-ended probe in ICDAS, it's always used in a lateral motion, not in a sticking motion. And it's only ever used to detect surface differences. So for example, if you were trying to determine between a code 2, where there's a scar, a white spot lesion, and a code 3 where there's breakdown of the enamel surface, you might use the probe very gently across the surface of the tooth. And likewise, when you're trying to detect tooth-coloured restorations, which are our bane, the bane of our lives in epidemiology, to try to detect those properly, you may use the probe very gently across the surface. Now, the only time that this is different is if you're doing a survey that involves root caries, because unfortunately I don't feel that the ball-ended probe is quite so helpful with root caries. But you can still do a lot of damage with a sharp probe on root caries. So again, it should be used laterally across the surface, very gently. And then the last prerequisite for using ICDAS is the one that actually you can do without if you need to. And that's the ability to dry the teeth with compressed air. As I mentioned, the very earliest signs of caries on a smooth surface require you to drive the moisture out of the lesion before it reveals itself to you. It's like magic. But you can do without that in an epidemiological survey, and we'll talk about a different version of ICDAS that will allow you to do that and to let other people know how you've recorded the lesion. So the first question, if you decided you were going to use ICDAS or consider ICDAS for a piece of research or a survey that you were doing, is how well could you meet the ICDAS prerequisite? The cleaning of the teeth prior to the examination has been done practically in many different ways in studies. I think the most practical way is to arm your patients or participants with a toothbrush prior to examination so that they have a thorough cleaning of their own teeth. But bear in mind that the areas of plaque stagnation are areas of plaque stagnation because the patient hasn't reached them very well for quite some time. And so they should bring the brush to the dental chair or to the table if you're in a school, and you can use the brush to help remove the other bits of plaque that they've missed. If you were doing a Caries clinical trial, you may want to go a step further and actually have a form of prophylaxis for the patients or participants before you begin the examinations. But thinking now about the different uses of ICDAS, in clinical practice, you should bear in mind that sometimes the presence of stagnant plaque is a very useful sign that you should be aware of. So there are pros and cons to having the teeth cleaned prior to examination, or to examining first and removing the plaque yourself. I mentioned extensively about the sharp probe, and I wish that we'd done this. The Eurocaries survey that I mentioned to you before, I said that we had some participants from the United States, and I don't think I've ever been more horrified in organising a training to see children being lifted by a probe from the table. Such was the force being used to detect caries. So I think it's safer to remove the probes altogether. And have any of you ever done studies where you've had a number of people look at extracted teeth? Anyone? Well, if you run a study where you actually use extracted teeth for people to examine, and you get lots of examinations going through, even with a ball-ended probe, I can tell you, at the end of several examinations, maybe 10 examinations, the surface of that caries has changed from people touching it with the probe. So actually very little pressure on caries causes damage. And as we've all taken an oath to do our best for patients, it's something to remember. So the compressed air thing. It's all very well if you're doing a survey where you're in a clinical setting and you have a 3-in-1 air syringe. Very straightforward. So the practical solutions that people have used in the field have included cans of compressed air. Have you seen those for cleaning your keyboard? It's a way that you can actually introduce air, but I don't know how hygienic it is, so I'm not recommending it. But we'll talk about the epidemiological version of ICDAS that can be used without compressed air. I think this computer only likes to move slides with flair. Many times, I cannot tell you how many times I have been told that ICDAS takes too long and is too complicated to be used in clinical practice and surveys. And yet ICDAS is being used all around the world in surveys and clinical practice. So I thought it would be useful to draw together some of the evidence that I've found as I've used it about how long ICDAS actually takes. Because I think you need to weigh up perhaps the extra time for the examination versus the extra valuable information that you gather. But being equipped with knowing how long it takes is part of the battle. So, In 2008, I was fortunate to be involved in the EGOHID survey. And this was a study, it's the European Global Oral Health Indicators Development Project. And it was massive. The entire study involved something like 19 different countries from Europe. But the clinical aspect involving ICDAS and other measures of oral health involved dentists from 9 different countries and 146 dentists. Now, because there are some practical issues to training so many people from many different countries, we used 2 different ways of training. And so I produced with my team some paper-based guidance and an electronic e-learning package to help train the dentists. And then they were brought together in each of their countries in smaller groups and trained face-to-face for half a day. It's really very limited training because it wasn't only ICDAS. It involved many different aspects of a dental examination. After this training, these dentists who were general dental practitioners or family dentists then went back to their clinics and they collected information for about 20 patients each. And so we had around 2,800 examinations completed. The examination was really extensive for EGOHID. There was some information on the patient themselves, just things like their age, their gender, some history of their dental treatment. The dental disease assessment was a full charting with ICDAS. There was a Dean's Index dental fluorosis examination, a yes or no for orthodontic treatment, an IOTN, community periodontal index, a full charting for loss of attachment, a quick note of whether there was a denture or not, and an examination of the soft tissues. And for each of these examinations over the 2,877 adult patients, the time taken for each of these elements of the examination were recorded. So how long does ICDAS take in the hands of new trainers with quite minimal training? Maybe quicker than my ability to change a slide. Okay, so you can see here, for the dental disease measurement, the mean time was actually around about 10 to 11 minutes. Quite a long time, but these were adults, and adults with quite a lot of restorations and caries. So you can imagine the difference between examining a child and an adult can be quite a lot. The minimum time was 0 for the patient that had no teeth. That makes an ICDAS examination very easy. And the maximum time recorded was 40 minutes. So that's not normal, I have to say. I think maybe somebody went for a coffee in between upper and lower arches. Interestingly, when you compare it to something like a periodontal assessment, looking at loss of attachment, it was a couple of minutes less than doing a full periodontal examination. So actually, this is the study probably with the most people examined that I've come across, that I've been involved in. And it's also the one that's taken longest. And I think probably because the dentists involved in the study had a very brief training before they went off and examined 20 patients. Ordinarily, through training, you would have examined maybe 10 or 15 or 20 patients before you went to start to conduct a study. And by that time, you're becoming relatively fast. So in Scotland, when I worked there, we had a very charming dentist who just threw up his hands and said, ICDAS, what good is it to me? I work in the National Health Service, time is money, and I have no time to spend in looking at this depth of information on my patients. I felt slightly horrified because I would hope that when I was being examined and my family were being examined, that there would be a thorough check to see what my caries risk is, as predicted by the presence or absence of early lesions and active lesions or not. But anyway, this very lovely man, Charles Ormond, agreed that he would actually conduct a study in his practice to look at the feasibility of using ICDAS, even though he was really quite against it. So I went to his practice and we did some face-to-face training after he'd done the ICDAS e-learning program. And then we looked at some images on the computer. And then I spent half a day with him looking at patients so that he got used to the ICDAS codes. And then he started his study, which was to examine 100 patients, the first 50 adults and the first 50 children that came in that consented to have an ICDAS examination. And actually all of his patients said yes, because our patients trust us. So he timed each of the examinations, and he usefully also timed how long it took to clean the teeth. So if you were planning a study, this is quite useful information. Although I think Dr. Ormond is a very speedy dentist. When you compare his findings to those of the ego head study, they're very different. So he found that for adults in the clinical setting, the main examination time was just under 4 minutes, and just under 5 minutes if you included the time to clean the teeth beforehand. And for children with fewer teeth and probably less complex conditions, it was around about 3 minutes per child, or 4 minutes if the brushing time was included. But actually, with Dr. Ormond, the most interesting thing was his change in attitude towards ICDAS. He said it did take too much time. But actually, the time wasn't in doing the examinations. The time that happened for Dr. Ormond was that his patients all of a sudden wanted to know more about their oral health. So the use of ICDAS in his practice engaged the patients in a discussion about having a code 1 or a code 2 or a code 3. And they wanted to know what it was. And all of a sudden, he was having discussions for the first time, strange to me, but for the first time, with his patients about the prevention of caries and about caries not being inevitable to progress towards a cavity and a filling. So he was quite surprised by this finding. Unfortunately, he saw that as slightly negative because, again, it took up more of his time. But for me, it was gold to find that the patients became more engaged in their oral health through the use of ICDAS. And he also found that having the teeth cleaned before the examination, he was suddenly finding so many lesions underneath the plaque. So it was a really good, tiny study, but very pivotal for him. So we've toyed with the idea of introducing ICDAS to national surveys in the United Kingdom for some time. And again, the resistance is very similar. It takes too long and it's complicated. Well, what we decided to do was to find out how much extra time it would take in Scotland. So we went to a high school, so the children there were around about aged 14, and we took trained examiners to examine the same group of children, so a little bit like the Eurocaries study. We had 24 children and 8 examiners, and each of them examined the same children. And there were different levels of examination. So we had 2 examiners who used something called the Basic National Dental Inspection Programme Assessment. And this is just a very simple screening. These dentists were looking at the child and saying they're either okay, or they need to see a dentist, or they need to see a dentist quite quickly. That's all they were doing. That's the basic NDIP exam. The next level, we had 2 dentists do this. And at the tooth level, they made a decision for each tooth as to whether it would fall into active caries, missing, or restored category. So a little bit like putting them into a DMF. And then the last epidemiological index that was used was the way that the epidemiology is conducted in Scotland, using very similar to the WHO criteria at the tooth surface level. We had 2 examiners do that. Now, each of these examiners were trained and calibrated with good CAPA scores for the national epidemiological surveys. And then we had 2 experienced ICDAS examiners, Dr. Chris Longbottom and David Ricketts, and they did a full ICDAS charting of the children. So let's see what happened here with the timing. So you can see here, the people that were doing screening were less than half a minute to decide which category the child would fall into. And the 2 examiners are quite similar. Same for the categorisation of the tooth into active, missing, or restored. Less than a minute, somewhere between half a minute and a minute. And the detailed examination, equivalent to WHO, was much the same time as you could imagine, because they're doing a very similar thing. And these are the ICDAS examinations. On average, under 3 minutes. So it ties in quite well with the work that Dr. Ormond did in his practice. Again, these are quite experienced examiners. So the take-home message from this is that if you were to include ICDAS in a survey, if we were to include it in Scotland, for example, we'd be looking at probably 3 times the time. But we're talking difference between 1 minute and 3 minutes. So not a great deal of time. Okay, so let's talk about ICDAS and it being complicated now. Because actually, when you first look at the criteria system, it is quite complicated. And in most of the studies that I do involving general dental practitioners, I ask them to have a sheet that has the codes, and they have it with them when they're examining. So they don't have to memorise and worry about getting them wrong. The feedback from the EGOHID study involving the dentists in 9 countries reported that it wasn't difficult to use in their opinion, but it was time consuming, as you could see from the findings. And Dr. Ormond also reported that actual fact it was relatively easy to use in practice also. So whilst it looks difficult to begin with, people do accept the coding once they actually learn. Okay, so I thought now I'd talk about some of the common issues. If you were going to train somebody in ICDAS, what are the areas that you should focus on? Because you can imagine that not all codes are equally difficult. Initially, people get quite confused with codes 1 and 2. And that's partially because we have different descriptions in ICDAS for codes 1 and 2 on smooth surfaces and codes 1 and 2 in the pits and fissures. And it's not because we like to make things complicated, but it's because the presentation of the disease is different in the pits and fissures and smooth surfaces. So on the smooth surfaces, we always focus in on trying to tell people to remember that the difference between a 1 and 2 is just simply whether it's seen when the tooth is wet or if you've had to expose it with dry air. In the fissure systems, it's different. And it's only different because the fissure patterns actually capture some staining. So in the pits and fissures, the caries is seen much more quickly than it is on smooth surfaces. So the differentiation between a code 1 and 2 in the pits and fissures is about how extensive the caries is, whether it's confined to the base of the pit and fissure or if it's going up the walls. So as the caries progresses, it becomes more involved, and you see as it starts to undermine in the pits and fissures, you can start to see down the edges, so it gets wider in the pits and fissures. The difference between a code 2 and 3 can be quite hard to see initially. And actually, the compressed air does help here also, or even a wipe with cotton wool. But for a code 3, you've got to be certain that there's cavitation of enamel before you would call it a 3. Otherwise, you would call it a 2. Surprisingly, for me, nearly every course, there's a difficulty for people in determining whether dentine is exposed or not. And I think sometimes it's because of the shape of pits and fissures, and sometimes you can't actually see the base of a cavity when there's dentine. I'd say probably the most confused code when we look at errors is between a code 3 and 5. And generally speaking, not too many mistakes are made about codes 5 and 6. But I used to be a member of the Magic Circle. If I had a wand, just make it better.